You're right, Jeffrey. Thank you, delegates and observers. I'd like to resume the standing orders. We'll come to resume the session. A couple of messages. Firstly, there has been no report of hot topics related to anything. Thus, I've advised Dr. Dobb related to the next session. Should there be great interest, it might expand. Otherwise, we break early, provide more time for either fresh air, a stroll, or preparation for our black tie gala ball. And the other important thing is there will be an opportunity to provide feedback to Dr. Feeney, who's the conference convener, about any issues that have come up related to this thing and of interest. It will be an electronic survey, so the questions, as I understand it, will go out to you, and then if you provide the necessary feedback. Take the opportunity to introduce Vice President Dr. Dobb, who will chair the next session.
Well, welcome everyone, and it's good to see so many people here for the post-lunch session. The final session this morning was perhaps the perfect segue into this one, in that it seemed that the politics of health are really about the politics of health funding. This session is on creating a market economy for health. And many of you will be aware that the AMA has been paying attention to the various reports and discussions about projected health costs over the next few years. We all know the numbers, and it's looking pretty grim. The AMA's Economics and Workforce Committee has been grappling with creating AMA policies for a sustainable health system. And this is a very difficult policy environment, particularly with the current fiscal restraints. At one level, the medical profession considers it has no role in worrying about where the money is going to come from. Just make sure there's enough for me to be free to treat patients in the way that I would like to treat them. But in reality, we know the medical profession has to be a steward of healthcare financing. We have to be engaged in the solution to ever-growing healthcare expenditure. Now, this doesn't mean that the answer is a reduction in medical costs, but it will mean spending the health dollar on medical care more wisely to get better bang for the health buck. Governments are much less able to control utilisation, but they're well able to control price, as we've seen in this year's budget. And as governments take steps to reduce the rate of growth in expenditure, or indeed cut their expenditure on health, costs will be shifted to patients. Consumers will be exposed to out-of-pocket costs and will look for and need other forms of insurance to cover these costs. It begs the question, is a market economy for health, and more specifically health insurance, the solution to both of these problems? In 2009, the National Health and Hospital Reform Commission recommended the introduction of a new health insurance model that it called Medicare Select to underpin the health financing reform. And the Commission considered that this would improve the responsiveness and efficiency of Australia's health system. Today, we've brought together an impressive panel to provide you with their thought-provoking perspectives on this topic. Professor Jess Solwinder, who is one of our speakers, was one of the key proponents for the Medicare Select model. And he's going to be talking about the alternatives for healthcare financing and what they could mean for the medical profession. Rowan Mead is an advocate for competitive and more commercially viable health insurance arrangements for more effective healthcare. And it might perhaps surprise you, those that aren't members of the AMA Council of General Practice, to hear that the AMA CGP has been looking at how the private health insurance market and general practitioners can work together to improve patient outcomes in the private sector. And Brian Morton's going to be putting some of their thinking into context for you. And with that, I hope that you're going to enjoy this session, and I'm pleased to invite Brian to the podium. Many of you will already know Brian. He is a general practitioner from Sydney and chair of the AMA's Council of General Practice. So Brian, welcome.
Thank you. As Dr. Job said, I am in full-time general practice, and I am lucky enough, I suppose, to practice on the North Shore of Sydney. And we've heard from the earlier speakers that that is probably an advantage in terms of health literacy, choice, and being privately insured. I guess the important public policy issues other than the federal budget deficit and asylum seekers, or the NDIS, or Gonski, there are some more important public policy issues, but you'd never guess it, as our speakers this morning said. Health is not a high priority issue at present with government. In the 2013-14 federal budget, brought down some 10 days ago, we saw no big initiatives and a number of cuts to the MBS. The underlying theme of the budget, the health budget, is to keep a lid on health spending. For that matter, neither side of politics is showing any signs of any plans to accommodate the increasing needs of an ageing population. Our purpose today is to discuss the budget not to discuss the budget in detail, but it is part of the context in which we now seek to do more with less. The government arrived with big plans to carry out reform in health, and in its first term, it deployed the National Health and Hospital Reform Commission. However, its findings and recommendations have not captured the public's imagination. Key recommendations were quickly shelved. The initiatives which have been implemented, such as GP superclinics, hospital reform, the Prevention Agency, Medicare locals, all have not had a noticeable impact on health services or patients. Being at the centre of the health system, doctors would have loved to have seen some genuine reform promoting better care of patients with chronic and complex care needs. We never lose hope that there will be an end to the blame game over public hospitals, but unfortunately, this latter phenomenon is alive and well, making many people sick in the process. The opportunity for real reform to the nature of Medicare itself or to Commonwealth-state relationships seems to have been lost for the time being. I doubt that such reform will ever arise from a relaxed review, but more from a crisis occasioning a direct electoral pressure from people as a result of serious deficiencies or from serious financial pressure on budgets, which must arrive in the next 15 to 20 years as a result of ageing, and as we heard, utilisation growth from patient demand and new technology, and unfortunately, less than optimal efficiency. At present, doctors and politicians seem to be in different planetary systems and different time zones. The political dialogue seems limited to a very narrow debate and about how we can reduce the cost of healthcare with a very short-term perspective. This has produced poor policy, such as inappropriate workforce substitution. Also, lip service is paid to primary care enhancements to decrease the long-term costs of healthcare, but no government is prepared to invest today's dollars. The evidence supports primary care, but this government's these state and federal governments lack the will to invest and the will to tackle the hospital-based system. The medical profession is vitally interested in how we can improve the quality of care for our patients with a much longer term perspective. So this session seeks to look at the scope for a more market-based approach to healthcare. I'm pessimistic about the possibility of major reform to the health system, although I will make some comments on the implications for general practice of some of the more likely major reforms, and I will consider what is achievable within the current framework, with change and reform at the margin. I'll leave it to the other speakers to perhaps consider the long-term possibilities. I'm particularly interested in how general practice would be affected by a different approach, since that is my field of practice. The federal government continues to feel a strong sense of ownership of the health system. Perhaps it's not unreasonable, given that they contribute roughly half the cost. But it doesn't help with its obsession with the bulk bill rate in general practice as the only barometer of quality practice, and it doesn't help when the Minister speaks as if GPs are salaried employees of the government. Is it conceivable that government would continue to make substantial contribution to health but have less hands-on approach in the way the money is spent and the regulatory framework around health funding and health insurance? That is a fundamental question for this session. Can we change this paradigm where patients can have a say more directly and through third-party payers such as the private health insurers? My own view is that major change comes out of a crisis, not a review, and we are some way off the crisis, and perhaps that's another 10 years. In the meantime, there are some useful changes we can consider. What we've got now is a system that the federal government dominates through its large role in financing. In rough terms, 59% from the federal government, 30% from non-government sources, and 20% from state and territory governments. Both levels of government maintain a very complex web of regulation of service delivery and health workforce. Their efforts are poorly synchronised and their relationship is often dysfunctional. Cost and blame shifting remains a huge preoccupation at both federal and state levels. There is very little financial or other involvement by state governments into primary care provision. Health is such a large part of their budgets that they are happy to opt out and have the feds bear the load. We spend less than 10% of GDP in health, and we provide a large number of high-quality, low-cost services to the community. Contrast this with the USA, where 18% of GDP is spent on health, and until recently, 40 million Americans were largely excluded from the health system. While health services in the US can be of very high quality if the patient has funding, there are fewer services provided per capita and at a higher cost. At the broadest level, our system is well regarded internationally, and in terms of life expectancy, perinatal mortality, and I'm sure you can think of others, our results are trending in the right direction. Of course, mental health and Aboriginal health outcomes are the notable exceptions. We have a mixed public-private system, and the contribution of the private health sector is still largely about financing private hospital activity, which is now a significant share of all hospital activity. It has very little role in other aspects of healthcare, particularly general practice. Policy failures abound and are mainly concerned with the high level of demand for health services in an advanced economy, and that's the irresistible force, coming up against the budget limitations of government, which of course is the immovable object. This leads, as we know, to service shortages, gap payments and waiting lists, which are a constant feature of our system at present. It has not been helped by a serious medical workforce shortage, and those shortages are still some way off from being resolved. Shortages and maldistribution will be with us for a while longer, and then we'll see whether workforce policy aims have in fact been achieved. In primary care, pressure on government expenditure has led the drive to 6-minute medicine. Yet I should point out that the average GP consultation is 15 minutes face-to-face. And that's despite the pressure and incentives to practice shorter consultations. The longer-term impact of cost containment is ignored by government for general practice. Fast throughput general practice leads to an increase in the referral to higher cost investigations and referral to higher cost and more specialised services. We know the patient cohort needs a different solution. Patients want time with their GP, and with the rise in chronic disease, there is a need for the GP to be leader and coordinator of the primary care team to maximise patient outcomes. At the moment, there's a tendency towards separate streams of care, but our strong preference is for this care to be provided within a more broadly resourced general practice, or at least coordinated by it. We need to do chronic disease management better. Time and complexity issues, and it is difficult for GPs. Time and complexity are issues, and it is difficult for GPs to provide the appropriate level of care within the current fee-for-service paradigm. There is a large non-face-to-face component which goes unremunerated, and coordination of care is time-consuming. Although we continue to believe that fee-for-service medicine provides the best outcome for patients, we think there could be a role for a DVA-type case management fee for an identified group of patients, such as chronic and complex care. It addresses many of the objections to the current situation and would be welcomed by patients, provided other normal entitlements are maintained. Such a case management fee would not substitute for fee-for-service, but must be and would be additional to it. In this way, doctors would not be discouraged from providing services to patients. And oddly, many policymakers see such discouragement as the main objective and achievement of their reforms. We find that hard to fathom, and I'm sure patients would too. Doctors get on with the job and do the best they can despite all the above. We could do better with a better policy framework. Diminution of the quality of general practice-led primary care leads to longer-term higher costs in health management. So, what of private health insurers? Currently, there's no great role for private health insurers in private medicine, except where that medicine is for inpatients, where the role is in relation to gap medical insurance and bed costs, theatre costs and prostheses. The federal government introduced the broader health cover concept in 2006, which was supposed to extend the role of the private health insurers beyond the hospital gate, but the effects of that have been slow and unremarkable so far. It is still true that the Health Insurance Act prevents the role of a private health insurer in the community setting for services covered by the MBS. I believe the other speakers in the session may discuss the concept of aggregating all health funding at the level of the individual and having financial risk reside with the competing health funds through insurance arrangements, introducing managed competition and eliminating fragmented responsibility and cost shifting. In this situation, the federal government would make a financial contribution as it does now and would provide the broad regulatory framework. I'll be interested to hear the discussion, but if private health insurers are left to their own devices to determine products and premiums, they may well decide against first dollar insurance. So whilst this may impact on hospital-based specialties, and it may be positive and protective against catastrophic gaps, in general practice it would be disastrous. Patients see the GP on average 5 times per year, and even small but gaps can discourage necessary attendance for some population groups. I'm not suggesting patients should not be exposed to gaps. Studies show that systems with charges for primary care have better outcomes than those where primary care is free. Other studies show cost sharing decreases spending without harming outcomes. At the moment, at least, government still limits PHI to a quite limited range of services. This works against holistic care framework, which puts the patient at the centre instead of the patient being a necessary inconvenience. Funders are far more concerned with how to shift costs onto each other than to take the steps that could foster a more efficient health system in the future. The overall financing structure has a far-reaching effect. The private health insurers are not going to look for new areas of expenditure when their revenues are limited and the government is withdrawing tax system support for private health insurance premiums. In this situation, the insurers will look for ways to support doctors to minimise costs to insurers such as the avoidance of unnecessary admissions and the reduction in length of stay for patients who are admitted. Whilst these programs may also be good for patients, the main driver is the reduction in costs to insurers from hospitalisation. So far, the private health insurers have behaved in an isolated fashion and have resisted overtures from the medical profession. The challenge is to ensure medical practitioners are fully integrated into these programs and not a token addition to the latest telephone counselling protocol. I guess in their defence, we're now in new territory, and in that situation, we all tend to strongly defend our own self-interest. The inability of private health insurers to provide health insurance cover for out-of-hospital services covered by the MBS is also very limiting. The genuine intersection of interests, the common areas of interest between the health insurers and the medical profession is in relation to pre- and post-operative care and for the privately insured and chronic and complex care, which if not done well, leads to hospital admissions. Although progress to date on these issues has been disappointingly slow, some insurers are starting to realise the potential and are developing packages to address this. They may need further encouragement to involve the medical profession in the development of these packages rather than to do them in isolation or with the advice of a doctor on staff. If done correctly, this would provide a tangible benefit for the privately insured patients over public hospital patients and would provide a service and quality-driven incentive to take up private health insurance. It would also provide better care for patients who would prefer not to be hospitalised if at all possible. Governments would find it problematic as it could easily be described as wealthy buying greater care not available to the less wealthy. They may be forced in the long run to match the arrangement, and I guess that would be a good outcome, or a bad, and that would be the bad outcome. A functioning PCEHR would be a bonus for these sorts of programs. The jury is out, of course, on that at present, despite the billions of dollars spent. So what's the potential? Well, it's actually enormous. The epidemiology tells us where the health risks lie: obesity, diabetes, alcohol abuse, and so on. The problems and trends in these areas are such that we may see life expectancy fall in Australia for the first time if we do not intervene successfully. As we were told yesterday, the numbers of obese Australians is rising exponentially. Diabetes Australia state that nearly 1 million Australians are diagnosed with diabetes, but 1.7 million may actually have the disease, and every day 280 Australian people develop diabetes. There is a role for government through broader public health approaches, but care still needs to be provided by the medical profession, and national messages need to be reinforced and activated at the patient level. The standout achievement, as we all know, in health prevention is the reduction in rates of tobacco smoking, but otherwise Australia does not seem to have made the most out of health prevention opportunities. A patient-centred system would allow the tertiary healthcare system to work in harness with the primary care system to improve health status. The implication is that private health insurers would be able to become an effective partner in health prevention, which is now forbidden, and that GPs would be able to work with private health insurers to achieve population health outcomes. How can we get the politicians to nibble? Well, given that grandiose plans have been made time and again and shelved time and again, perhaps we need to start with a small slate. The more enlightened private health insurers are starting to develop programs which will capture the interest of the medical profession, and we need to give a clear signal we are open for business, and that I gladly give today. One fund has discussed with us the idea of an integrated care solution. This program does focus on the area of intersection of interests, which is chronic disease management and pre- and post-discharge admission planning. The health fund involved, Medibank Private, has developed an integrated care package which has applicability in the public sector as well as the private sector. The package does see a key role for general practice in the management of chronic disease and the pre- and post-admission management of patients. The package is in the trial phase, and at present we're discussing it with the fund. A missing piece in this package at the moment is appropriate remuneration to the GP, but we're hopeful of rectifying this in due course. This package is a good start, and we hope to be able to improve it through discussion and for other funds to follow. Working against us in dealing with politicians, however, is that such programs have a long-term framework and can affect health outcomes for an individual into the future. But of course, politicians cannot think beyond the next opinion poll or the next question time. We need to be able to show that GP-led teams can deliver, and that for the AMA is the catch-22. So to wrap up, the government has not yet got the macro policy framework for a greater involvement of the private health insurance with general practice. Progress has been disappointingly slow, and it is only recently that some of the private health insurers have engaged with GPs and others to further their mutual interests for the good of patients. Some broader health financing reform, which better integrates the public and private care sectors and liberates medical practice from the current strictures in the Health Insurance Act, would go a long way to breaking down the barriers and improving patient care. But it would be a greater crisis than we have now, or perhaps a political leader of much greater vision and calibre that we can see on the horizon. If there was some genuine reform, truly based on the notion of better patient care, there is considerable scope for health programs currently aimed at prevention and better managing chronic disease, of which there are so many, to be brought together in a more rational GP-led framework with private health insurer involvement and better health outcomes. Thank you.
Thank you, Brian. It's now my pleasure to welcome Professor Jas Stoelwinder. Jas will be known to many of you. He is the Professor and Chair of Health Services Management in the Department of Epidemiology and Preventative Medicine at Monash University. Jas has studied the implementation of a Medicare Select style of insurance arrangements in the Netherlands, and he's well able to put them in the context of the Australian health system, and delighted to have you here today.
Thank you very much, and I'd like to thank the AMA for inviting me. It's been decades since I've had the opportunity to address the AMA, and I just want to, in my defence, point out that I was once in my youth on the West Australian Branch Council. So anyway, but many, many years ago. But it's certainly a delight to see the AMA in action in such a forum. And also, being in the postprandial session, I thought what I should do is just give you a quick summary of what I want to say, and then you can go to sleep, and I'll do the rest of it for my interest. But in essence, what I'm going to argue is that if you have a tax-funded health system, then how much you spend, or how you earn your revenue, if you like, is the result of a political process. And that the result of that we'll explore in terms of the numbers. And what that leaves is consumers or the public at large, largely outside of that decision-making process. It also, in a tax-funded system, means it's one size fits all in terms of how the system, and I think that's a relic, if you like, of 19th century thinking about service provision. And how the market comes in here, what I want to argue, and in the blue box there, they're the various elements of health financing that you have to think about when you design financing. And you have to raise the money, you have to pool the money, and then you have to purchase services. And it's in the area of purchasing services that I think the idea of Medicare Select plays out, which is to have a competitive marketplace, if you like, of purchases of healthcare, and whether that would drive consumer engagement, choice, and better cost control. So that's the thesis. We'll see how well I can present it to you. I'll stop using my iPad here. I didn't realise I can see what I'm talking about down below. I thought if I got up here I wouldn't have a clue. Anyway, I've got a couple of clippings of the AMA, or as it used to be, the British Medical Association brackets Australia branch contribution to the health policy debate, because essentially if you have if you have solidarity in healthcare, and what I mean by that is that you don't pay for healthcare according to ability to pay. If you have that, which is what we have, then you have to have some form of cross-subsidy, because someone pays. And so it's either a cross-subsidy through tax, which is an income cross-subsidy, so rich people subsidise poor people, or as in private insurance, low-risk people subsidise high-risk people, which essentially means young people subsidising older people because of the structure of healthcare costs. Now, we had that debate in Australia for very many years. In the 1930s, the first slide up there, we nearly went to an NHS, and we got a very hostile debate between the medical profession and the government at that time. The war intervened, and so it went to the back burner. And then the government reintroduced, initially, some of you, those who are of my vintage, will remember the Pharmaceutical Benefits Act. And this was in 1945, and you can see the BMA objecting to that scheme. And in case you can't read it, in the middle there it says, it was not a measure designed primarily to provide the public with so-called free medicine, but under which the government hoped to socialise the medical profession. Anyway, it was an interesting time, and clearly the medical profession played an important part in that political process. So we eventually finished up in 1953 with a National Health Plan, which is the sort of pre-Medibank period, where we essentially had voluntary health insurance, and you might remember the pensioner medical scheme. So that debate about insurance versus tax funding we've had, and then we finish up with Medibank Mark I becoming now Medicare as a tax-funded healthcare system. Now, I think what's quite, in most Western countries, the setup of health insurance or health funding arrangements are essentially an end of 19th century, first half of the 20th century event, when it was largely related to income security rather than health provision itself. And I think this slide, which I've got, I'm going to turn this off, but you don't, but do have now. This slide is from the New England Journal of Medicine recently, and on the top it shows you the mortality rate of admissions to the Mass General Hospital, and at the bottom is the average cost per discharged alive patient at the Mass General Hospital. And for those of you who are watching the right-hand screen here, you can see that around about 1950, modern medicine took off. And the insurance schemes and funding schemes were all introduced around here. So, what? I've put this slide up just to show you what's happened to costs since we introduced Medibank. So this indexes health expenditure back to 100 in 1960-61. And in the mid-70s, of course, we had our national health insurance, and you can see what's happened to health expenditure in terms of GDP. or what's happened to real growth in expenditure, and this is per capita growth in expenditure. So that's a sort of play out, if you like, of the ability to do things on the one hand and a tax-funded health scheme on the other. And in insurance terms, we call that moral hazard, in the sense that if I get services that I don't pay for, then of course I'll have them. If I order services for people who don't pay for them, of course I'll order the service. Now, the long-term implications of that are probably best shown in the intergenerational report that the Treasury put out every now and then. This is the 2010 intergenerational report showing federal government expenditure. Now, in the first graph here, I hope people over there can see where I'm pointing here, but the graph on your left-hand side, don't worry about the brown bars, but the blue bars are the federal deficit. In other words, the difference between income and expenditure from the federal government. And you can see here the impact of the GFC. There's a negative gap, and then we go through quite a long period of predicted positive gap, and then eventually we go into a negative, long-term structural negative gap. Now, so this is federal government financial position as projected going forward. Now, over in the top right-hand box are the contributions to that federal spending and what's predicted to happen to them from now to 50 years on. And you can see health expenditure is the major contributor of all of the federal government programs to that. So much so that currently federal government, so this is before the current hospital reforms, the federal government is spending about 4% of GDP on health. It's going to double. And the next little bit of question about sustainability is the per capita expenditure. And in the bottom right-hand diagram, and the blue bars are the impact on expenditure as a result of ageing of the population, and the brown bar of the bar is the impact of more services per person. You probably realise that there's a long-term trend of about 2.5% more services per person every year, adjusted for ageing. That really is a question of sustainability of our tax-funded system. I think one thing to point out is that that pressure is still some way off, and in a sense it really depends on what happens to the economy overall, how much pressure will be applied to the government to do something about this from a fiscal point of view, completely separate from considerations of health policy. Now, I used to call this proposal Medicare Choice. When the Reform Commission implemented it, they called it Medicare Select, but I'm now going to call it the AMA Plan, because if you read this press clipping from 1975, by your president of the day, Keith Jones, who I remember. I'll just read it out for you. Australia cannot afford the government's national health insurance scheme with the present state of the economy, according to the president of the Australian Medical Association, Dr. Keith Jones. Speaking to a Canberra Woden Rotary dinner on Wednesday night, Dr. Jones, it's surprising when you read these old clippings how many of them come from a Rotary dinner. Anyway, that must have been where you did your politicking in those days. But anyway, speaking at the Rotary, it said the government making healthcare available to all individuals free of cost is a right, as a right, was a blank cheque that no country can afford at the best of times, least of all a time of economic recession like the present. It was not to deny that every individual should have access to medical treatment, but it was to deny the rationality of offering free service to patients who could afford to pay something. Anyway, so how do we design a system that engages consumers in what it costs for healthcare, but isn't a payment for a service when you need a service? And this is what I think the real challenge is. Now, I've what to do about it, I've divided the rest of my talk into what happens in the real world and what might happen in a dream world, which is where I live. The real world is where you are, and this is really just a bit of evidence that the decision-making about what we spend now is a result of political processes. And you read it every day in the newspapers. The whole Reform Commission debate came out of the 2007 election, when essentially Howard was saying all the states are run by Labor, they can't run anything, they can't run the hospitals, so we'll fund the hospitals directly. And you might remember the Mersey Hospital in Tasmania was put up as one that we will fund directly. And of course oppositions don't want to get too far in front, because then if you say something you might be held to account for it. So you have a Me Too political response. And so Rudd, who was then, you might remember, the leader of the opposition, took over that line as well, tell the states get well soon. So immediately it's a political environment. We have the Reform Commission, we have billions and billions of dollars promised. At the end of the day, it all turned into a political fight about the role of the states versus the role of the Commonwealth. Commonwealth wanted to take over the running of the hospital system, and the states want to hang on to it for God knows why. And essentially, if you look at the Reform Council decisions leading into the implementation of the reforms, they're all about the states clawing back control. And the most recent example we had, for those of you from Victoria, we had this 107 million that the federal government took out of the Victorian hospital budget because of corrections to the population statistics that the formula was based on. We had 2 weeks of this, and then the minister capitulated. Victoria got its 107 million back because it ran a campaign, and the shareholders claimed the credit. And I think the irony of it all is that when the federal minister tried to explain her decision in the newspapers through ads, she was referred to the Auditor General's office over misuse of taxpayers' money for party political advertising. So that's a kind of very quick snapshot of how politics plays the decision of what we spend on healthcare, rather than any sense of consumer choice. So what do we do about it? I think there's 3 options. One option is to tweak the current system. That's what we will do, that's what we're doing, and inevitably that's what we'll keep on doing. We can go towards a national health model, and most of my colleagues in academia promote that. So it's essentially built on the National Health Scheme with regional health authorities and pooling funds at the level of regions or states. Or you can go into a market-based consumer choice model, which I argue for. Now, I think to change the dynamics of this, we need to do a couple of things. We need to change the politics of it and have individuals engaged in decisions about how much we spend on healthcare. I think we have to get to a single funder. There's some design choices. You either get to single funder at the level of the individual, so everyone's money is in one bucket, or at a level of a population. This Medicare Select type model puts the money all at the level of the individual, whereas people who want a national health insurance scheme model want it at the level of a population. And then the role of choice, competition, and this level of purchasing that I referred to already. 5 minutes. Okay, so Medicare Select that the Commission proposed was that the Commonwealth would be the sole funder, tax-sourced, that your Medicare entitlements would be delivered through health and hospital plans, so competing plans, which might be insurers but might be other structures of plans, that everyone would start, if you like, in the Medicare plan, but then opt out and join, say, Medibank Private or Bupa or Australia Unity plan, which would allow them to bring their private insurance and public insurance together, and then those plans would contract for services both from the public and private sector. The government said, interesting proposition, we'll look at it, but before we look at it, we'll fix the health system, which is, of course, what they've been doing the last 4 years. Now, there are a number of design options that can go beyond the Medicare Select that the Reform Commission proposed. As I said, that was an opt-out model, and which still just essentially had a tax-funded system. It still didn't engage consumers directly in the cost of healthcare broadly. And the model that is based on the Dutch scheme has an arrangement where consumers pay part of the premium, the government pays part of the premium through a payroll tax, and then the government subsidises people for the premium they pay according to income. So everyone has a vested interest in purchasing their health plan, if you like. So how that could work in Australia, the Reform Commission calculated that if Medicare benefits were paid for out of income tax, now you appreciate Medicare benefits currently paid out of general revenues, all sources of government income are just in a big bucket. But if we paid it just out of income tax, it would represent 14% of income tax. Okay, so you'd have to have a 14% income tax to pay for Medicare as we know it now. Now, one way of dealing with this is you could take half of that, say 7%, instead of paying it as income tax, pay it as your Medicare levy and have it hypothecated. So if it's hypothecated, you would link the spending of healthcare to the growth in the economy, because that money would reflect the growth in salaries and wages. Consumers could pay, like private health insurance, a premium, and then so people are paying a dedicated payment for Medicare, and you reduce their income tax over here so that it's neutral, and then you allow people to join different plans. You regulate what services have to be provided, so essentially Medicare services need to be provided. Now, I'm conscious of time, and I'm conscious that Rowan is still to speak, and we want to leave time for questions. So I'm going to leave it there, but I've got, I appreciate, and I said right at the beginning, this is a very complex thing and it's almost impossible to give you a feel for. But what the story is about is to argue that we currently have unsustainable growth, that part of the reasons we have unsustainable growth is that essentially moral hazard. The consumers don't know what it costs, and the vested interests engage in the political process to push the cost up. And if you had a competing health plan where consumers were paying a significant amount but subsidised back through their tax, then you would have a significant basis for competition around plans that could purchase healthcare. That is the application, if you like, of the Dutch insurance reforms that they've had since 2006 to the Australian scene. I only say that because it might sound fanciful what I'm describing, but the fact that it happens in one country means that it can happen. But you'll see that the political difficulties of getting something like that to happen are very significant. So I wouldn't lose too much sleep over such a managed competition model.
Thank you, Professor Stallwinder, for introducing us to the complexities of a Medicare Select type model. I'd like to just remind you that you can send in questions still using your iPad or phone. And I'd like to thank Steve Wilson, Tom Stanley, and the many anonymous questions that have been put so far. But if you're happy to put your name with the question, then that'll be good. But we'll also be taking questions through the microphone. The final speaker in today's session, this afternoon's session, is Mr. Rowan Mead. Delighted that he's part of the panel today because he brings a unique perspective to this topic in his role as chairman of the Business Council of Australia's Healthy Australia Task Force. Under Rowan's chairmanship, the task force has prepared a paper titled Microeconomic Reform to Deliver Patient-Centred Healthcare. This paper highlights that the gap between the projected demand for healthcare and the capacity of the healthcare system to meet that demand is growing, and that there is a need to address that gap at the same time as we have the economic and financial pressures that we heard about this morning. So, Rowan, delighted to invite you here.
Good afternoon, ladies and gentlemen. I'd like to start with my conclusion, if I might. We're facing a future of government-managed care and growing rationing of health services. The only way out of this future will involve the increased adoption of elements of a market economy. We should and we can work together to achieve this. In support of this conclusion, I plan to do three things. First, I'm going to talk about where we find ourselves now in a system based on a 200-year-old history of acute and episodic treatment, a system where producer interests all too often trump patient interests. Second, I'll describe to you the future without change, a future of greater demand for health resources, a future where the needs of the patient remain a lower order consideration, a future of ever greater government control of care at all levels, and the inevitable consequence, rationing. And finally, but most importantly, I'll offer some thoughts on how an infusion of market economy elements into healthcare can help build a positive future for the sector. In particular, I want to focus on two market economy elements: improved patient-centred care and improvement in the safety and quality of healthcare driven by greater availability of health information. I'll look at that second point in some depth. Both these elements would give more power to the consumer, balancing producer interests and providing the environment for market forces to generate valuable innovation and improvement. One, where are we now? Arguably, in economic terms, today's healthcare system, if it can be called such, can be characterised as an arrangement of producer interests, an arrangement with any number of voices raised, all claiming the consumer or patient interest, but a notably weak voice of the consumer or patient themselves. I cannot think of a more emblematic, evocative or resonant description of this circumstance than Inge Clendenin's limpid sentiment in her book Tiger's Eye regarding her treatment for major liver disease. It goes something like this. I soon learned in hospital that it is the vertical people who have all of the power. This arrangement of producer interest runs deep. We're talking about a 200-year-old or more process of institutionalisation, a process that has produced an imposing edifice of healthcare buttressed by powerful elements. These include information asymmetries between clinician and patient, funding arrangements for activities and not outcomes, persistent industrial practices that shape relations between clinicians, between primary care and specialisms, between clinicians and allied healthcare. Capital formation processes that strongly influence the allocation of capital to physical assets and certain types of physical assets at that, for instance, acute hospitals. Demarcation and boundary management issues riddle the sector. Training models too often reflect and entrench existing boundaries, and relationships with bureaucracy are inflected by government's many and sometimes conflicting roles, including as funder, regulator, and as itself a producer. So what's wrong with this edifice, towering over the patient and the community? Hasn't it, the healthcare sector, made remarkable contributions to individual and community well-being? No doubt. But if we are to help Inge Clendenin's prone patient stand up for his or her interests to be determining, it will be part of the process of recognising that the existing producer arrangement is frankly unsustainable. Why? Well, not least because its form is fundamentally imbued with the acute care and episodic treatment history of the healthcare sector. Meanwhile, the disease challenge that it was originally configured around has vastly shifted. In parallel, technology and managerial systems have leapt ahead, leaving the healthcare sector flailing expensively, trying to deal with chronic disease, explosions in scientific knowledge, and ageing populations with the sector using increasingly outmoded industrial, technological and managerial models. 2, a future without change. This is why, in my submission, our current economic configuration in healthcare is already rationing and managing the care provided to patients. Perhaps the most visible to the general public of this phenomenon is the waiting list. But there are many other areas in which rationing is occurring, from the drug supply through to training and supply of clinicians. The effects and extent of rationing are set to grow significantly in coming years as our ageing population, not to mention our own appetites for healthcare due to our affluence, makes more and more demands upon the system. Rationing is, of course, increasingly managing care and defining the way in which clinicians practice. Even in the areas of apparently uncapped funding, such as Medicare and general practice, we see that the on-the-ground reality of funding drives our important primary care layer towards a potential future where it is little more than a triage service. These issues are set to become more visible in coming years, in part just because of the sheer size of healthcare as a proportion of the economy. Currently $130 billion per annum in outlays across all players. The growth rate of these outlays in dollar terms is already some $10 billion per annum, accelerating. A Deloitte Access Economics report released this month by the Business Council of Australia projects that on the basis of current policy and including the 2011 health reforms, health spending as a proportion of total government expenditure will rise from 13% in 2009-10 to 21% by 2049-50. For the states and territories, the projected increase is from 25% to 40%. Deloitte also projects aged care costs to rise for the Commonwealth from 15% to 25% across the same timeframe. This means that a projected 46% of federal government spending will need to be spent on health and aged care together in less than 4 decades hence. Money, however, is only one dimension, and I'll just call out 2 others to ponder. A, healthcare and social assistance is already Australia's largest workforce segment at 1.4 million workers or so. The segment is likely to seek another 1 million workers over the coming decade. B, in 10 years' time, we will likely have more Australians suffering dementia than we will have Tasmanians. Healthcare's involvement in the real economy, as opposed to just the financial economy, is much more significant than a glib phrase like 10% of GDP can ever convey. My third section, key changes for the future, patient-centred care and quality improvement through information. So, given the massive interest that I've described, why in the world should we be encouraging our poor, prone patient to get to his or her feet and shake a feeble fist at this mass of interests, this Leviathan? Surely the more comfortable prescription would be for him or her to take a Bex and continue lying down, with hope that no writhing or rationing happens nearby. But this, in a nutshell, is in fact my submission to you, that it is in fact in yours and the community's long-term interest to see that patient differently empowered and differently served by the healthcare system. That we must reshape the current, seemingly convenient arrangements to arrangements where patient and consumer interests are truly powerful determinants of the configuration of the sector and its services. This, after all, is a key feature of a market economy, an economy where consumer interest, convenience and power balance producer interests. And why would such rebalancing potentially improve the socio-economic sustainability of healthcare? Because, again, in my submission, reorientation around properly informed consumer interests will support new levels of effectiveness, appropriateness and efficiency in healthcare. A complete laissez-faire market? No. Keeping a mixed economy is crucial. Let me be very clear. I do not believe that Australia's healthcare system would work if it operated under some adolescent conception of free market. On this point, Nobel Prize-winning economist Paul Krugman's view is persuasive. That is, that healthcare is simply too different, too complicated and has too many intangibles to simply allow sick people to pay for care as needed, and too inequitable if we were required to do so. Sicknesses that require expensive treatments don't necessarily discriminate between rich and poor, and often hit the poor harder due to lifestyle factors. Geography too comes into play. The sector that we see in operation today has many features that we should value as strengths. It is a mixed economy with high clinical quality, public and private facilities, public and private funding, and a broad functioning primary care layer. How do we improve? How do we resist rationing? How do we institute effective reform? A sector reorientated around the patient will assist in the development of valuable market economy elements, reducing waste and directing limited resources to where they have most value, and help establish a pathway to better quality, safer, more effective, efficient and economically sustainable healthcare. My other contention is that significant gains in healthcare quality and safety in Australia can be made through greater freedom of access to health information. Last week, Peter Harris, Chair of the Productivity Commission, gave a speech noting the potential size of those gains, focusing particularly on the quality of care in Australian hospitals. Mr Harris cited his Commission's 2013 report on government services, which found wide variations between hospitals in terms of the cost per patient separation. He said that the report showed, on average, that the healthcare sector was operating about 10% below its own best practice levels in terms of hospital care, with the scope for productivity gains in the order of 4 or 5%. He said this was extraordinary, given that the Commission often considers gains of 0.5 to 1% significant in other sectors. The value of improvement in these areas, waste aside, could be in the order of $3 billion per annum. Mr Harris said that if instituted, not only would these potential savings be made, but there would be vast improvements in the quality of life for many Australians using the hospital system. I must say I do find it extraordinary that the Chairman of the Productivity Commission can flag up a vital service sector of the economy that is running on average 10% below best practice. Do I want to be a patient or taxpayer knowing this as I walk through the hospital door? Access to pertinent information is vital to any functioning market. It is no different for health. In my view, it can lead to better health outcomes for individuals and a more cost-effective healthcare system. In fact, today I would issue a call to arms to clinicians, government and the broader health sector to cooperate in a concerted push to make health information more accessible across the board. Of course, privacy remains a concern, but a concern that can be addressed within a framework that understands just how valuable this information can be to both patient and to the budget bottom line. Let me explain further. Hospitals. You'll no doubt be familiar with the work undertaken by Ross Wilson and others that led to the seminal 1995 paper, The Quality of Australian Healthcare Study. The headline findings were startling at the time and remain so. Reviewing the medical records of more than 14,000 admissions to 28 hospitals in New South Wales and South Australia, they found that 16.6% of admissions were associated with an adverse event, which resulted in longer hospital stay for the patient and was caused by healthcare management, 1 in 6 episodes. And half of these were considered preventable. For nearly 1 in 5 of those adverse events, the outcome was permanent disability or death. Yes, there was carping at the methodology, and yes, there was a later study in 2000 seeking to standardise the way in which to calculate adverse events with the US literature. That recalibrated the rate of adverse events found by the original study towards 10.6%. But even so, I ask you to ask yourself the question, what if this were right? Should I be happy walking into a hospital knowing I have a 1 in 10 chance of something going wrong, half of which might have been prevented? What if this is even halfway right? If the percentages in the report are still accurate, you can extrapolate that the number of deaths in Australia from preventable adverse events may have now reached a conservative 20,000 per year. I put it to you that if any other sector, the construction industry, for example, or the hospitality industry, had a record of industry-induced deaths approaching that of our health sector, there would be massive effort expended in identifying, reporting on and mitigating the causes of these private catastrophes. You may argue that it is unfair of me to use a study from nearly 20 years ago to make the point in 2013 that we should be urgently examining the reasons behind such a high incidence of adverse events. I would put to you, though, not when there hasn't been a similar comprehensive study done since, and not when publications like the Medical Journal of Australia are pointing out 10 years after the initial study that Australian hospitals were no safer in 2005 than they were in 1995. But this isn't a blame game. Don't think for a second that this is a finger-pointing exercise. I, for one, congratulate the National Health Performance Authority for its report this week on Staph aureus infection rates in hospitals. This is the first time this data has been put together in such a comprehensive and transparent manner, with both well and poorly performing hospitals named. My sense is that it will lead to better behaviours. More often than not, what we are talking about are systems management problems, and there hasn't been a systems management approach and industrialisation of procedures to improve safety and quality of care. Let me illustrate with a recent example from one of Australian Unity's members. We had noticed from her claims history that 64-year-old Jean had been in hospital a number of times after sustaining several low-trauma fractures in previous years. Our Remedy Healthcare business, which provides clients with targeted evidence-based programs for self-management, contacted Jean. Jean advised that she had experienced menopause in her late 30s, and despite having sustained multiple fractures since and from fairly minor events, had never been tested for or treated for osteoporosis. We advised her of our concern about the likelihood of osteoporosis and strongly encouraged her to approach her GP to consider a bone scan. The result was a diagnosis of advanced osteoporosis. Over 20 years, Jean's condition had resulted in claims to our health insurance fund of $15,000 in unadjusted dollars. But Jean's osteoporosis story is far from over, as everyone in this room knows. She is likely to need more hospitalisations and interventions in the future because of the extent of the progression of her disease. Jean's loss of amenity and the associated treatment costs might have been avoided. What do I take from this example? First, it is a sad fact that over 20 years, 20 full years, none of the various GPs, emergency room doctors or surgeons who had treated Jean had correctly identified her condition or commenced treatment. Second, it's an indictment of the information systems in the health sector. Australian Unity, through Remedy Healthcare, has 20 such programs as the one that Jean had, looking for patterns of illness and disease amongst members to determine a more effective treatment regime. Other health plans are also tackling this challenge, as you heard Just say. But generally, we only have access to hospital records. We don't have access to primary care data. I ask you to imagine the improvements in understanding of patients' long-term patterns, health patterns, if data were more broadly available. Third, it shows once again that the patient simply is not at the centre of the healthcare system. How much different might Jean's situation now be if the focus had been on patient outcomes rather than activity? Finding out if patients got better rather than finding out if they were treated, measuring their health at regular intervals post-treatment, making use of this information for both this and other patients, while at all times keeping privacy top of mind. We need to get serious about this, hence my call to arms. We need to clear away the impediments to creating and sustaining the fundamental information bases that will open the sector to continuous improvement. Noted paediatrician Donald Berwick, the former CEO of the Institute of Healthcare Improvement in the United States, spoke eloquently last year about why the US remains a long way from providing its citizens with patient-centred care, which he says would offer better care at lower cost. To illustrate his theme, he pointed to veteran US cardiologist Bernard Lowndes' contention that half of all revascularisation surgery using stents for stable coronary disease is unnecessary, offering no better results than a patient simply managing his or her own health. Berwick doesn't ask you to necessarily agree with Lowndes' findings, he just asks you to ponder the possibility that they are true or even half true. He ponders, more than 600,000 stents a year are used in the US, so what happens to the heart hospitals, the surgeons, the stent vendors? It's scary to ask. Where are the policy settings in healthcare that make sure that we persistently probe the system for pattern failures, appropriateness and outcomes assessment and ask the scary questions? Ross Wilson's study posed some scary questions in 1995 and we haven't revisited those since on a national basis. Across the industrialised world, there are many fellow travellers on this reform journey, the reform journey that I've touched upon today. Increasingly, many of the individuals at the forefront of reform, such as Donald Berwick, Atul Gawande, Terry Platchek, Just Stolwander, are leading clinicians who are dissatisfied with the quality of healthcare systems. Whether it is the improvement movement or proponents of checklist and cookbook medicine or lean management advocates, we see learnings imported from industrial and managerial practices in other sectors. These imported practices are artefacts that have been produced by decades of refinement by the forces of a market economy in those other sectors. But these transplanted artefacts face the ongoing risk of tissue rejection. We need reform for the whole body or edifice of the healthcare in order for these practices to become the norm, a norm associated with better quality as well as reduced cost. A sharper focus on patient-centred care and improved performance information are two key steps on this most important reform journey. The clinical world that unfolds along the way, while different and confronting in aspects, will ultimately be more satisfying in that it will be linked more transparently to the long-term well-being of individuals and communities rather than to regulated practices and procedures. Thank you.
I'll be taking the remainder of the session from this position so I can interact with the technology as well as managing the questions from here. What are we trying to get out of this session? And I think what Federal Council and the Council of General Practice would like to get out of this session, as well as the content of the presentations here today, is some feel for from the people who are here today, those people who are attending National Conference. Perhaps some of the questions that we might be posing to you as well as to ourselves are, should general practice get into bed with private insurers? If we do, what are the risks and benefits? Another question might be, are the out-of-pocket costs for Australians excessive? Should insurers be paying more? Should government be paying more? Or is the effect that we saw in the last budget, that is patients paying more, is that a trend that we wish to see more of? And perhaps most fundamentally, how can we ensure universal access, which is the principle of Medicare, and at the same time keep down healthcare costs and maintain quality in our health system? Because all health systems around the world are grappling with those three issues: cost, quality, and access. And I would suggest to you that no health system in the world has yet got all of those perfect. Many people think that the Australian healthcare system is essentially a bit of a Ponzi scheme, in that we have survived for decades on the principle that the new taxpayers coming into the system are sufficient to sustain the healthcare costs of our ageing population. But we're now getting to the point where the new people coming into the scheme perhaps can't sustain the costs of Australia in the future. So we will take comments as well as questions from the microphone, but I will limit comments to 90 seconds, at which point I will thank you and ask you to step away from the microphone. So if anybody wishes to come to the microphone, please do. While you're coming there, I'll perhaps synthesize a question which related to Professor Stollwinder's presentation, which is that we heard quite a lot about the structure and process of the system, but what are the outcomes? And has the system that has been introduced in the Netherlands reduced healthcare costs? Has it improved patient outcomes? What effect has it had on access to care? And are people in that country happy with their system?
Well, thank you very much. There's a lot in that question too. I'm still struggling with trying to present the scheme in 20 minutes. I'm going to struggle to answer all those questions in 20 minutes, I think. I'm going to start backwards. Are the people happy with the system? There is a Swedish academy that regularly measures people's satisfaction with their health system, and it's a consumer-orientated questionnaire, so it's not a clinical outcome, but really is the system responsive as perceived by consumers. And the Dutch system regularly heads that of the European systems Now, as an anecdote, one of the things I do when I travel, when I call it the taxi driver test of the health system. When I get a cab from the airport to the hotel in a country, I always ask the taxi drivers what they think of their health system. Now, the Dutch spend per capita the same as we do. Their economy is about the same as ours. And the amount they spend, so I've already said the amount they spend on healthcare is essentially the same as ours. But when you ask a taxi driver, the classic answer is, we have a terrific system, but it's very expensive. And what that means is that the cost of the system is explicit to them because they're paying a payroll tax, which by law is half the money spent on healthcare. So there's a formula link of spending on healthcare rather than a political budget decision, and they see it. And then that contributes 50% of the funding. And then the rest of the funding, government pays for children 18 and under. The rest of the system, they pay directly to their health plan, which is about €2,000 per adult. So they see the cost directly. And so there's that element of the system. Now, the problem of, the evidence base of policy is a very fraught question. In policy, we tend to take a perspective, what we call a path dependency perspective. The trajectory of a current system really depends on its history, where it's been and its structure, and it isn't a kind of controlled trial of whether this intervention has a good outcome. And if you think about it, the introduction of the NHS, the introduction of Medicare, none of these systems had evidence, if you like. I think all you can do is look at the dynamics of a design of a system and say, well, how could those dynamics work in our system, and do we think that would be better or not? It's not going to be an evidence-based decision.
Thank you. As to the, despite the comments made yesterday, the microphone is still not being attacked, but we do have a lot of questions using the new system. The question I'd like to take next is, and really to the whole of the panel, is if we were to move to a more competitive system of health funding and healthcare provision, which might look a little bit more like the US system, but without all of the, but with better access to healthcare. What do you see as being the risks in that? And in particular, this association has had long-term issues with the approach that is taken by some of the US managed care systems. How do you think that that might be received in the Australian context? That's Rowan.
Okay. Happy. I suspect that last part might be something where opinion ventured by me might be controversial. I suppose the first thing to ask about managed care is, well, what do you want? The alternative, unmanaged care? I mean, it's important that we don't use phrases that actually shut down discussion versus tease it out. I think the opportunity that I think exists in a more industrialised and managerially sophisticated approach to healthcare management for populations and for individuals is that we can actually deploy technologies and expert systems and properly share information and be timely and be responsive in ways that we just can't be today in the sort of fractured cottage industry that we exist within, which is not to prescribe for a second some sort of monolithic, institutionalised healthcare. Far from it. I think the opportunity is for distributed healthcare, which is much more intelligent, which is more supported. And I just reference our own experience as a health insurer who's put our money down on chronic disease and healthcare and allied healthcare management systems. And we see ourselves entirely interacting, particularly with primary care, to actually be supportive, to be effectively an outsourced office of intelligence and connected data and opportunity in reality, rather than something that is trying to prescribe on some sort of fly-by-wire basis details of medical practice. Far from it. And I actually think modern technologies allow us to leapfrog that old industrial model entirely.
I just might comment on that. I think language is important here. Managed care, it's important to define what you mean by the word. Excuse me, for me, in my thinking, managed care is about the shift of financial risk to providers. Okay, so that providers take on the financial risk for the care of a population or a group of people, and then what are the dynamics that flow from asking providers to be financially at risk for the care of members. Now, a lot of what people call managed care, I would call purchasing of care, if you like. Now, I want to make the distinction between funding care and purchasing care. So Rowan, as a private health insurer, can be just the payment agency, and so we've got an agreed billing structure and he just pays the bills. Or he can take the view, I'm the steward, if you like, of the financial spending on health that my members have contributed to me, and what are my responsibilities in terms of purchasing care, in terms of the characteristics of the care, the questions that you raised, access, quality, cost. Now, that trend to purchasing is going to happen anyhow, and I think one of the futures we face is that governments, because they're spending more and more on health, are not going to just keep funding it. They're going to be more active purchasers, and you'll see that in state health departments' relationships with hospitals, for example. They're progressively becoming more of a purchaser. Now, I think what the managed care debacle in the States taught us was that by restricting access in managed care, there was a consumer backlash to that. And so I think what we need to design is a system where you've got competitive tension around what healthcare costs, what it's purchased, how we're purchasing it, and at the other hand, delivering what consumers want from their healthcare. Because that'll be the sort of balance in the system that I think Rowan was referring to in terms of getting better balance between consumers and providers. Now, just to quickly finish, there's two places where that can happen. One place where that happens is when services are delivered in the doctor's rooms or in the hospital, or the other place is when you buy your plan for the year or for the next 2 years. And what this program Medicare Select's about is really to have that purchasing tension when you buy your plan of healthcare, but not at the time that you deliver healthcare.
And if I might, I think it's very important just to note in relation to the HMO experience in the US, which I think we're all conscious of, the fundamental statutory legal position in Australia versus the US that one can never forget is that we have an open enrolment system. And all of the discussions that Justin and I have been talking within have been on that supposition that we continue to have an open enrolment system where insurers, funders, purchasers, whoever they may be, cannot risk rate, that they must engage with the community and the individual's health.
Brian, say something to this.
I guess from a GP and also an AMA person, it's really, the challenge to us is, do we want, dare I say it, an academic or a health fund-led change, or are we prepared to actually put aside the rhetoric we've had, the knowledge we've had about managed care, have a look at it in terms of what the government does to us now and how it manages the care? So I'd suggest we need to be open-minded about it, and whilst being open-minded, we need to be a little bit more proactive, thinking about how we see healthcare being done in the interests of the patients, and dare I say it, as physicians, how we see healthcare changing, and that's going to be the challenge. We want the best for our profession, but we also want the best for the patient, and that's not necessarily dictated by an economist, a politician. It's best dictated really by doctors.
1 2 1 2 1 2. Paul Neskins, GP, Harvey Bay, just west of Fraser Island. My question is largely to Brian. You talked about funding the chronic disease management. I have concerns about dividing, making sure we remember the difference between treating the patient and treating the disease. If we introduce a system whereby a certain amount of money is linked to a chronic disease label, in real general practice, not specialist practice where people are disease specific by being there, but in real general practice, we're going to run into the trouble of having an epidemic of the label. I think if we're going to talk about patient care, it's got to be about the whole patient, acute or chronic, young or old, not chopping them up into labels. So do you think that chopping the patient up into classifying them as a particular type will be a risk?
Right.
Yes, I think you're right. And most of the discussions with government over chronic disease management is the limitation of the guidelines or descriptors as who's in and who's out. And really, as GPs, we deal with the whole patient. And what I guess RACGP and, dare I say it, AMLA are also saying, as AMA does, that we don't want restrictive descriptors of how we can manage our patients' care. They are different. Each patient has different needs, and we need that sort of thing open. We do, however, need to recognise that chronic disease and the ageing population is going to be a massive burden on our system. So we need to think, I think, outside the square, but also keep it open in terms of how we manage patients according to their need, not a prescriptive list.
Rowan, do you want to say anything about that, given that some of the private health insurers are getting into this chronic disease space, and I guess the AMA has had concerns that their programs aren't well connected to their primary care, their GP provider?
Look, I'd support everything that was just said. I think it's tremendously important that we mustn't lose sight of the individual. And going back to your introduction, I think if there was a more intelligent way in which health insurers could participate in the appropriate funding of GP practice, such that exactly that can be preserved, rather than trying to fund some labelled disease, would be much to be preferred to where we are today.
Nicholas Gaddis, medical student representative for AMA Queensland. My question's directed to the whole panel, but I think perhaps Mr. Mead might be best placed to answer it. Big data is one of the most disruptive innovations to come to managerial and industrial systems at the moment, and it's already very much in place in the retail industry, in hospitality, on retail banking. In healthcare, it promises the sort of predictive analysis which has never been possible before. My question is, how might big data be used and introduced into Australian healthcare to both improve patient outcomes and to manage cost? Do you think current moves towards it, such as the PCEHR, are adequate? And what do you think are some of the barriers around its introduction and use in the near future?
Thank you. That's an enormous question, almost as big as the data that you're asking about. In short, I think the answer is that big data could be a very powerful tool in the hands of clinicians and others in the healthcare sector. I don't believe that the PCEHR is anywhere near, as yet, an adequate platform for that. There are too many fragmented pools of data across the healthcare system, and we need to join them up. It seems to me that our federal government made the classic error in relation to the PCHR commissioning. It seems to me that governments can actually be very good IT developers, except when they get their hands on the levers themselves. I think a government is a much better software developer when it says to a sector, thou shalt do something by such and such a date, and put regulatory gradients and funding gradients and other things in place such that you get the sector to get together and work out what are the solutions that are going to generate the result. I think it's tremendously dangerous to reach in yourself and try and determine and architect that result from the perspective of the government. I think, whoever's there, it's very difficult. So I think, sadly, it's the old Irish joke, if you're going to Dublin, I wouldn't start here. But having started here, I think we can slowly muddle our way to Limerick at least, and I think it's going to be a very powerful tool in the near future.
Sorry, I was just going to indicate I'll take the final two questions at the microphone, and then I have one from the electronic system before we finish this afternoon's session.
Thanks, Jeff. Tony Joseph, emergency physician from Sydney. I read recently that I think 20 hospitals in the UK in the West Midlands are struggling severely under the unprecedented patient load, particularly of elderly and chronic illness, such that they're saying they can't provide safe care at the moment. That was just in the last week or so. And I guess in our emergency departments, we're suffering a similar onslaught of elderly and chronic complex illness patients. So I guess to Rowan in particular, but the rest of the panel, I mean, we've noticed in the last 10 years or so, a graph I saw recently say that the provision of medical services has increased mostly in the over 65, particularly over 75 and the 85. How would the industry tend to manage that? Because clearly it's not sustainable, and I guess I'm interested in yours and Brian's views on that as well.
Start, John?
No, yep, I'll start if you like. I think I'm saying too much. Yes, no, I think that's very interesting, and you reference to the UK situation. I don't know if you've been reading it this week, but the Health Minister, Jeremy Hunt's been under fire from the College of General Practice in the UK because he's blamed the significant increase in emergency department attendances on the lack of after-hours provision of services by general practice with their new contract. And but anyway, I think it raises the point for me. I mean, I experienced this problem. I should declare an interest. I chair the board of Ambulance Victoria, and we're experiencing the same accident emergency demand pressures as the emergency departments do. And one of the things that strikes me is that for ambulances, we provide, in a sense, a single response to someone who rings 000, you know, a couple of people in a truck with sirens. Whereas when you look at those people, there's a huge gradation of urgent need they have, a lot of which is primary care, a lot of which is nursing services, and a whole range of other types of services, but the default position is the emergency department. And so I think that the problem really rests in, you know, what's the service system that sits in the community and how is it organised, and what is the role of accident emergency departments in that. One of my colleagues, Peter Cameron, is an emergency physician. His view is that the most efficient way of dealing with this problem is actually just to have emergency departments, but make them bigger, that a community-based system, you know, won't respond. So anyway, so that's debate, but I think it is in the structure of the system, and I think I might ask a question of Brian, because it seems to me, you know, a lot of that is about chronic disease, isn't it? And decompensation, if you like, of people with chronic disease. And I just wonder whether general practice has the organisational structure to develop systems of care that can deal with this on a 7-day-a-week, 24-hour basis.
I'd suggest that we don't, and we never will, and nor should we. I mean, some of the reality is that when you're 85 to 90 with chronic comorbidities, you're going to die within 2 years, Pat. You know, the stats that were shown earlier this morning. I think also we need to recognise that if 2% of the population use 40% of the health costs, how are we going to actually handle that? It's not appropriate for someone to come to my surgery after falling downstairs with a fracture or whatever it is, who's 85 or 90. The appropriate place is actually in hospital. And so I think there are a lot of times when we say, well, managing chronic disease better is in ignorance of reality. People get old and they die and they're sicker at that age group. So we need to look across the whole system and say, we're not doing it well now. Let's recognise that we can't prevent all ill health, and at times the proverbial will hit the fan and you'll need to be in hospital. Sometimes the patient goes to hospital, can be discharged, and it was totally inappropriate, but it's the aftercare. Where do they go if they live at home? So I think we really need to stop and think that we can't solve all chronic disease management issues through prevention. People eventually get old and die.
Richard Kidd. Two parts of the question. One is a little bit unrelated to the other. The Commonwealth Fund...
Richard, can you just pull the microphone down?
The Commonwealth Fund 2011 showed that Australia actually spends more on out-of-pocket expenses than any other country, including America. 39% of the population spends over $1,000 a year out of pocket already. So our patients already, in terms of what they're paying for privately, are determining some of what services they get. And I'd appreciate some comment about that. But the main point I wanted to bring up today is we're looking at this explosion of cost, which is really mainly hospital. It's not primary health care. And Brian has given a nice segue into where I want to go with this, and that is what we really need to be talking about is futile care. We really need to be talking about when do we stop putting a huge amount of money into people inappropriately and really move them much more appropriately into palliative care, and have the discussion with the 96-year-old that having a heart valve replacement or a hip replacement is probably not in their best interests.
Yes.
Thank you.
Is that a question for insurers or for clinicians?
I think the second half is certainly for clinicians, but on out-of-pockets, I think we need to be a bit mindful of comparing between countries on raw out-of-pocket expenditures. The complexity of comparing a open enrolment community-rated system with a risk-rated system which has 50 million lives uninsured, such as the US, is problematic, and so I think there's an issue there. But just to give you a practical behind-the-scenes reality of the political pressure, and this is how you feel it. Insurers every year have to front up to the health minister, federal health minister, and deliver a number. It's a number that the health minister has to announce politically. And if it is 0.5%, if it is higher than last year, that's a political problem. It's a little known fact that we're actually by law required to put in a number which actually isn't the tabular rate of increase in Australia. It's a lower number. It's the forecast contribution increase number, which for various complicated reasons is lower than actual inflation. So there's already some managing of the type of number that goes into the public arena politically. But in trying to develop that number, insurers are put under extraordinary pressure, including to look to out-of-pockets, exclusions, waiting period limitations, and all sorts of other benefit limitation periods and so on. This is an outworking of the political discourse that just referred to.
Just on the electronic feed, Dr. Ford, our Treasurer, has pointed out that what people spend on out-of-pocket expenses is in fact quite small, quite modest. The recent survey suggested about an average of $125 a week on medical expenses, which is, can't even get a cup of coffee a week for that. So in comparative terms, what people are paying in Australia is quite small, but they are paying a lot more out of pocket for, in particular, for drugs and other things that they buy from pharmacies, drugs, appliances, and so on, which I think is about 3 times as much as they spend on medical gaps.
Well, I think, I mean, one of the things is the out-of-pocket costs in Australia were hugely more before Medicare. So we have had in our history much larger, as a percentage, obviously, not in real dollars. But the point about out-of-pocket costs is someone has to pay. And so you either pay yourself or someone else pays on your behalf. And as I said at the beginning, that's either a taxpayer or it's a spread of insurance risk. And so the taxpayer payment is really a political question, and I think that inevitably out-of-pockets will increase because the pressure on costs will force the government to put more burden out of pocket. So then you have to ask the question, are those costs more appropriately insured, by which you mean should we pool them and share them according to risk in an insurance pool? Now, then, I mean, that raises the question of what insurance is for. Is insurance for frequent, low-cost items of service, or is insurance best for high-cost, infrequent, unpredictable? And so there's a real kind of policy debate, I think, that we have to have about, you know, what outcome do we want there in terms of out-of-pockets versus insurance versus tax.
I'm just going to take one last question. So.
Dominic Barbaro, GP, Victoria. From what I gather, this is a more sophisticated process than the coordinated care that was carried out by the divisions both in Victoria and in Queensland in aged care, and where the money was pooled and was doing much the same things that we are discussing here today. I have some problems in that I need reassurance for when particularly we're dealing with private health insurance, which is a new introduction to this, is what assurance do we have that the task substitution that we are very concerned about is not going to actually increase because it might be cheaper, and also the capping of medical services, is that going to be considered at all in this process? So I'd like some answers to those questions, because they're very, very important to me to know that I can carry on seeing my patients much the same way, and if anything better, rather than doing less than I'm able of doing it at the moment.
I think they're very important questions, and certainly possibly too difficult to be definitive about at the detail level. But for example, just at the general principle of capping of medical expenses, insurance arrangements in Australia today are still legally on the basis of a contract of indemnity. If the cost is legitimately incurred, we must pay. So there's an indemnity principle in the insurance that I think is entirely connected with community rating. So I think any adjustments to that at a policy level would be very significant adjustments, and that would be a matter for considerable debate. In terms of task substitution and efficiency and so on, well, if it's in the patient's interest and that the evidence shows that a program of care is best delivered in a particular configuration versus another, well, that's a matter of evidence, and I'm sure we'd all be on one page that the patient's interests trump that. But at a more practical level, in terms of dynamic change in a complex sector, I think there is a certain level of baseline comfort that should be taken here, even if we're talking about quite significant re-engineering of processes and orientation. There's one thing which makes the medical sector, the healthcare sector, profoundly and utterly different from, say, for example, let's call it the car manufacturing sector this week, is that this is a growth market, and volume is the issue we're facing here is volume potentially overwhelming us versus some other type of problem. So I'd submit to you that the adjustment issues that we're facing across the sector are potentially more benign than in some sort of market that is collapsing or eroding. Just as a measure of that, I'll give you two decadal, the previous question was on aged care or ageing matters, give you two decadal periods and three numbers to reflect upon. 10 years ago, and think about your own practice and public policy in relation to aged care and medical practice. In 2003, 324 Australians turned 75 each day. Today, 10 years later, 366 Australians turn 75 each day. That's an 11.5% increase over that decadal period. Looking ahead a decade, just drawing on the ABS data, in 2023, 10 years from now, 595 Australians will turn 75 per day. That's not an 11.5% increase like the last decade. That's a 62.5% increase in the coming decade. And so I think we're all about to live through some very interesting stresses in our healthcare arrangements.
Look, thank you. I'm going to call an end to the questions at this point. I'd like to thank all of our speakers. Brian, for giving us a view from the coalface of general practice. Professor Stellwinder, for a dream that we can perhaps look towards, and perhaps hopefully it's a dream rather than a nightmare. Yeah. And to Rowan, for perhaps challenging us with some questions, at least as much as we've challenged you with the questions today. I'd like to thank also those who came to the microphone and those who sent the electronic questions. Apologise if we didn't get to some of the later questions, because yet again the system has failed to cope with the onslaught of comments, which is perhaps something that we need to look at if we use this system again in the future. So thank you for being here this afternoon, and thank you to all our speakers.
There is a presentation. Good. Look, thank you. As I foreshadowed, I'll adjourn our conference slightly earlier. It will assist the President to attend a meeting on internship processes. I'll also advise there's a thank you gift that we'll present to each of the speakers. I'll remind you that the gala ball is at 7 p.m. tonight. The venue is in this room, and we'll resume our conference at 9 a.m. on the 26th of May 2013 for the policy session, Health has a Postcode, Society's Ills and Individuals' Health. Thank you very much. Conference adjourned.
Can you hear me calling out your name? You know that I'm falling and I don't know what to say. Speak a little louder or even shout. You know that I'm proud and I can't get the words out.